Welcome, everyone. Thank you so much for attending our webinar today, a first panel style webinar for the Doctor Care family. I wanted to introduce myself. My name is Maral, and I will be moderating our discussions today. Just so that you know, we are recording this webinar, so we will make it available to our physician community. And if you do have any questions along the way for our panelists, by all means, please jot them down in the chat box. We will be holding a Q&A session right at the end of our discussions. So with that in mind, I did want to introduce Paulo, who is the founder and managing director at Doctor Care, who's going to introduce our wonderful panelists and then pass it back over to me so we get our discussion started.
Thanks, Maral. For this discussion, we really wanted to bring together a cross-section of physicians with different practices and experiences so we could bring a diversity of perspectives. Let me introduce everyone. All very good friends of us at Doctor Care, and we're extremely grateful that they're taking some time off or some time today to offer us some of their perspectives. First, we have Dr. Andrew Vellathottam. Andrew leads a faux group of 9 doctors in Scarborough, representing a large and diverse patient population. He's part of a family health team and works in a community with 3 other physicians. He also acts as medical advisor for med tech startups on the regular. Next, we have Sofia Nastis, Dr. Sofia Nastis. She's a community-based physician practicing solo. She's in a small foe of 5 physicians in North York and has a special interest in preventative medicine, obesity management, and virtual care. She also does home visits at the Hellenic Home Senior Housing Center. And finally, Dr. David Price, who's professor and chair of the Department of Family Medicine at McMaster University. While he spends most of his time in administrative and policy spheres these days, he continues to practice comprehensive care, including palliative care, general family medicine, and covers the newborn nursery at McMaster University Medical Center for about 6 to 8 weeks a year. Thanks again to our panelists and all of our attendees for joining us. I'm going to turn it back over to Maral to dive in.
Thank you so much, Paulo, and thank you to our panelists for joining us today. So before we get started, I wanted to provide a bit of context as to why we decided to put this webinar together. We have heard day in, day out about the impact COVID has had on your day-to-day clinics and your patient care. And so we wanted to bring together a group of physicians that could speak to their experience and get a sense of what has and hasn't worked for them and how they've adapted along the way. Before we get started, though, I wanted to ask you, David, as a GP who is very active at the policy and systems level, what are some of the provincial learnings that you can share with us in our audience today that is relevant to the primary care community during the COVID pandemic?
Thanks, Maral, and thanks for having me on this. So I think that what we've seen provincially is that when the pandemic hit in March, our number of in-person visits really dropped in primary care. And we went from sort of 800,000 visits in primary care per week, and that dropped really down to about 30% in person. There was a certain amount of virtual care that happened, and you could see the tipping that as the number of in-person visits went down, the number of virtual care visits went up. We got as low provincially to about 30% in-person visits. We're now back up at the end of September, somewhere in the 50-50. So about 50% virtual and 50% in person. And interestingly, we are now just above, at the end of September, we're just above the number of overall visits being provided by primary care as we did in 2019. So we started to see that trend come back, and we're providing the care. There's been some challenges clearly in trying to decide who to see in person and who to see virtually. Some guidance, I think, got confused early on, and there was some guidance from the ministry and from others saying, hey, we should be doing everything virtually. And that clearly is not the case. And CMPA and and CPSO have both been coming out with pretty consistent guidance recently saying, look, you need to provide care, and it's a clinical judgment and a discussion with your patient as to whether that's done in person or virtually. And so really it's trying to figure out what the balance is. We've been looking at some of the provincial data though, and there's two real lessons that need to come forward that are something that we're going to have to address in primary care. The first is a really significant backlog in preventative care immunizations. We were just looking at some numbers a few minutes ago, and it looks as though in the under 25 age group, we have probably close to 100,000 immunizations in this province that we are behind. So in other words, at the same time last year, we would have provided well over 100,000 more immunizations. So this is pretty significant because this is childhood vaccinations. The numbers in the over 25 is more like the 40,000 deficit, but this is a huge deficit broadly. We're also seeing that in cancer preventative care, FIT testing, mammograms, pap tests, etc. We know that some of this, of course, is based on the system not being able to cope with it, but there is really a catch-up. And the last thing I'll say is that we've been hearing at the provincial level from hospital CEOs, from emergency room physicians, this narrative that primary care isn't open and that our patients can't get in to see us. And we know, based on the numbers that I've already presented, that patients can get in to see us and that they are getting in to see us. We also know that the amount of mental health distress that our population is under is significant, and it means that there's an increased demand on us in primary care and when providing care, simply because a simple visit for diabetes, blood pressure, whatever used to be simple, is now simple plus. You've got the simple thing that you need to deal with, plus the complexity of mental health. And so there's a real challenge. And part of that is going to be that primary care just can't provide everything in all places. And I don't need to tell this audience that the demands on primary care have never been greater. And so we really need to craft that narrative and respond to it. So thanks for having me.
Thank you, David. All very relevant points that I will say I definitely hear from the physicians that I deal with day in, day out. And I'll actually start right at the beginning of your piece, which is having to make these major adjustments to continue providing care to your patient base. So Andrew, why don't I start with you? Could you tell us a little bit about how you had to make very drastic changes very quickly in order to meet the demands of your patient base when all of a sudden patients weren't as keen to come in, virtual care came in, and how that has changed over the last number of months? And then Sofia, let's hear from you as well to get a sense of what you did with your respective practices.
For sure, and thank you for having me. I think, like every other doctor, it was a big transition. And I think the one fortunate thing I had in my place already is that I was actually already signed up for OTN. I already had some phone visit efficiencies and protocols already in my practice. So the transition from going from inpatient at about 100, maybe about 95%, and I was still doing telephone about 5%, basically flipped. So now we're at 95% virtual or telephone and 5% in visit. It was a lot to do with the infrastructure that we had in place at our current clinic. At my clinic, we had 3 other doctors. We're all practicing, normally all of us during the day at the same time. Then all of a sudden we had to switch to staggered schedules, which I'm sure other people had to do in group practices, and then allow our phone lines to accommodate the number of people that would be calling in. Because it now wasn't just people calling in just to book appointments. It's because they called in, they missed their phone appointment, they got to call back and book again. In the beginning, we had it as I would be on the phone and simple things like going through, okay, I need a blood test on you. I need you to get this X-ray ultrasound. In the beginning, the way we had is call back my office, and then we'll fax it off, we'll arrange it for you, we'll get it to you. I think what we did to adapt from that point till now is we started to embrace more of the tech that was available. So I personally run on Accuro, and what I found helped to improve my efficiencies essentially in that point was, okay, we have now secure messaging. So my appointment now runs as, I need you to do X, Y, Z. I'm now going to just email that to you. right at this moment. So then there's the additional steps of them calling back for imaging and diagnostic lab and all those things. We can reduce that burden on our infrastructure that we had built in the clinic. So that was just, I think, embracing some of the additional tech that was kind of there helped us to transition a little bit smoother. But obviously it's an ongoing learning session, because we still have a number of infrastructure issues with telephone lines too much, but we're just trying to sort out and trying to educate our patients on how to use secure messaging. And the other aspect we brought in was the online appointment booking, and getting those patients who are capable of doing that to start using it, to flipping to that, so that the burden on our staff isn't as high.
And did you find the uptake across the board amongst your colleagues in your clinic, so that you can get a consistent messaging across to your patients?
So again, just as diverse our population is, we have a diverse physician practice as well. So we still have doctors in our practice that are paper-based. And we had doctors who are EMR based. So adopting that technology and what is there was a little bit more difficult for those other physicians. But what we tried to do is centralize it to our staff to execute most of it. And then those docs that were kind of still more paper-based, they were able to still function within the realm. And obviously there were some hiccups with them. But I think what we are learning, and one of the big learning points from the whole COVID point, is we're on the precipice of adaptation of virtual care and all these things. And as ongoing learners, as physicians, we're ongoing learners. I think we also have to learn, not just in the medicine side of it, there's obviously how we execute that medicine is also part of that learning process. So there was that, but I mean, it's kind of growing and growing pains that come along with the whole COVID situation.
Thank you, Andrew. Sophia, what has your experience been like from the middle of March to current day?
For sure. Thanks for having me as well, you guys. And so as a community family physician in North York, I can provide maybe a little bit more insight to those on the call today that are based out of maybe some smaller scale FOs. So I'm in a 5-person FO in a couple of locations in the city, working 4 days a week. And so basically off the get-go is trying to make sure that the patients realize that the access is still there and that we were available. So with regards to administrative staff, it was of paramount importance to make sure that we had them on call, always there every day of the week that we were previously working, and the same hours that we were available. And it's just that the physicians themselves, including myself, weren't potentially going to be physically in the office, but still accessible to our patients. So essentially what myself and my other colleague who I share an office with is that we set up alternating days in the office. So I work 2 days in office, 2 virtual days, and we alternate just to make sure that the patients feel that they have that access in person as well, not just front loaded to the beginning of the week versus the end of the week. And the way that we had our patients kind of appreciate that the access was available is making sure that not only were we accessible over the phone, but we also implemented using virtual care booking services. And so virtual care was rolling out a pilot through Southwestern Ontario through the eVisit Primary Care Expansion Program. And I believe Think Research was kind of spearheading that initiative. And so they expanded that to all of the province. And so when I saw that that was available and covered by the province itself, I thought that that would be really useful to implement into the office. And so we sent out batch emails. We let patients know that if you want, you can book or request your appointment through this online messaging system. For the most part, it has been a younger kind of demographic using that system, but you'd be surprised. I have 70-year-olds messaging us on the virtual care platform asking for appointments for, a UTI or, whatever that they're wanting to kind of deal with. So we shouldn't generalize. We should try to make sure that we're open-minded for everyone and not just assume that only a certain population is going to embrace the technology, because I've definitely experienced a wide range of acceptance from my patient base, who is quite diverse in and of themselves as well.
That's actually really good to hear, because that definitely is an objection that I hear in the field about a certain patient demographic and the physician being a little apprehensive about how open to adopting technology they are going to be. So it's good to hear that you've had a positive experience and it's worth the try, because from both your experiences, it seems like technology has definitely helped offload some of that burden that otherwise fell on you at the beginning when you had to adapt really quickly. With the need, with the need to bring the right patients in now, because you're still not at a point where you're open like you were pre-March 2020, and you can see whoever you wanted to see in person, just like Andrew, you were saying, 95% of your visits used to be in person typically. How are you assessing which patients to prioritize to bring in and reaching out to the patients that may be hesitant to come in and yet do need to come in? How are you determining those two in your day-to-day to make sure that the right patients receive the right care in person and then the rest virtually?
I think this is a very difficult question because it's in terms of, and I'm sure David can speak to this as well, as we have the CPSO, CMPA, Ontario College, all these various guidelines. And if you basically run through it and get to the end of it, at the end it says clinical judgment. So what does that mean? In my head, I weigh it the same way I would explain to a patient. I take the risks and the benefits of them and I basically go from that point and explain that also to the patients who are apprehensive of coming in and those also who demand to come in, because it's both sides as well. And then there's people in between as well. So I wish I could just give you the one answer that just kind of qualifies all, but it is very much clinical judgment. I think that's why the onus then comes to the physician. That's why we're trained. That's why we should have it. But I think every decision I make is basically based on that risk benefit analysis and explaining that to the patient as well, why they can or cannot, let's say, just in terms of those who want to come every day, let's say, can't come in every time. So that's, sorry for the general answer, but that's kind of how I look at it.
And what would you say your split between in-person and virtual has become right now in terms of what your week looks like?
So right now, I think it's probably in line with what David said. It's probably about 50-50 right now when I'm in clinic. 50% of my visits inpatient, 50% are virtual. That being said, I do take one day that's completely virtual. So that day, maybe it's a little bit more favorable, maybe 60-40 split right now. But because we have 4 physicians in clinic, we do have the option, luckily, that if I'm talking to someone and I do need them assessed right away, I can make a call to the physician working that day in the clinic, and we all have access to each other's records, and it's a simple call to get done. And we're still open, Monday to Saturday, 9 to 8 or whatever, or 8 to 8. So luckily, that's in my case. That's not understandable, not in everybody's case, but we have that coverage available.
Sophia, for you and your clinic partner, has there been anything else that's come into play in really figuring out who to prioritize to come in for the visits for the in-person, or encouraging or discouraging patients to come in or not come in?
So I think just right now, from a timely perspective, I think a lot of physicians are looking towards, and with regards to influenza and upper respiratory season kickstarting, and worried about, how are we supposed to manage these specific patients? Many physicians, including myself, are worried, like, how do we triage these common infectious presentations? Who are we bringing in? When are we bringing them in? When are we concerned in, bringing them in sooner rather than later? I actually recently attended a Choosing Wisely webinar, and it provided a really great resource to safely and appropriately triage those URI flu season patients. I can post the link later on in the webinar, but it's called Choosing Wisely, the Cold Standard. And it's actually a really great resource for those who haven't checked it out yet, just to get some quick pearls on trying to manage, in the context of this patient is COVID negative, swabbed and confirmed. How are we supposed to manage them virtually versus seeing them in person? And, when it comes to things like sinusitis or otitis media, and, they're like Andrew's mentioned, you have to really gauge the patient, weigh the risk benefits, and basically educate the patient if you feel that they are reliable, potentially providing post-dated prescriptions, educating them, providing and emailing them a viral prescription, making them aware of the red flags of when they need to seek in-person care. It's going to be more important than ever now to make sure that patients are also accountable for their own health, and it's on us to educate them to make sure that they are accountable. because before it was just a quick pop in, patients could walk in, patients could call in really quickly. Now there's added layers of complexity to seeing even your family doctor. For example, in these types of situations where we're worried about, is this pneumonia? Is this just viral bronchitis? The Cold Standard Choosing Wisely resource has been a really enlightening kind of handout that I've looked at to try to make sure that I prepare myself for what's to come, because we are going to be getting into these diagnostic dilemmas where we worry about, should we be bringing these patients in now versus waiting versus letting them kind of ride things out at home.
It's probably important to add that having provincial information communicated out to all of us is going to be essential as we move forward in the flu season. Right now, there's virtually no influenza in Ontario and or Canada. So it helps to triage people. Certainly there's a lot of rhinovirus out there and significant challenges with that. The other thing I think that is going to be important for us to help communicate both to our physician colleagues and our patients is, PPE is available for family doctors. There is no shortage of PPE. We know that if we utilize our PPE appropriately, if we apply the IPAC standards, there has been very, very little transmission of coronavirus to healthcare providers. I know that there was a recent surge in the number of nurses in British Columbia, for example, who have acquired coronavirus, and they are scrambling to try and understand whether or not they acquired it in the workplace or outside of the workplace. And it looks, I don't want to generalize because I think the study is not completely there yet, but it's looking, as my understanding is that more often than not, it's from outside the workplace. And so we know that if we adhere to what we know how to do in terms of PPE and IPAC, we can protect both ourselves as healthcare providers and our patients. And that probably needs to be better communicated at the provincial level to reduce some of that anxiety about coming in and also providing care.
Thank you, David. And on that note, we've been hearing from the GP community how challenging this flu season has been with so many patients needing the flu shot, and they're not necessarily being the supply in the GP's hands in order to provide it. What's it going to look like for the primary care community from your experience when the COVID vaccine rolls around and most patients are going to be scrambling to get it from their primary care providers?
What we didn't see in this rollout of the flu vaccine was a really robust engagement of the primary care community. I'm chairing this primary care advisory table, which is made up of family physicians really from across the province. And our message to the ministry and through that table to the health collaboration table, the former command table, has been, look, primary care is here. We are used to giving flu shots. We would like to be, and we should be, at the coordination and organization and planning table to bring the best of the primary care knowledge into this. And I'm hopeful that as we move to the COVID rollout, which, fingers crossed happens early in 2021, that primary care can play a really significant role. We have 40,000 patients in our FO here in Hamilton. We have already exceeded the number of flu vaccines this year than we did last year. We have another 1,000 or 1,500 booked in the next 10 days. So we have the capacity to deliver high numbers. And there's some really innovative models in Toronto, in Ottawa, in Peterborough, in Guelph up north. And we need to build on that for the COVID. So if folks have innovative models, I would love to hear from you in your own community as we're going to try and roll this out provincially, because I think primary care has a huge role to play in this, and probably the key role, notwithstanding some of the cold chain challenges that we're all going to have to face over the next little while.
One of the things you mentioned in your introduction at what's going on at the systems level that's impacting primary care was preventive care efforts. And that's something that I've absolutely been hearing about when I interact with the GPs that I work with. and the challenge of dealing with the backlog, because there were limitations to being able to provide preventive care, screening, vaccinations to your patients when the pandemic hit. And now things are loosening up. And so you're able to send the appropriate patients that are overdue for screening to get it done. But how do you address that? And what are you finding, Andrew, Sofia, I'll turn it to you. What has your experience been? And what are some tips and tricks that you may have that you'd like to share with the audience about how to ensure that the right patients that are overdue receive the screening and the vaccinations that they need this year for their preventive care services?
So preventative care, now that it's kind of openly accessible for us to restart, for a while now, it's been the, PAPs, mammos, fits. It's just a matter of making sure that you take advantage of every opportunity that you have with the patients, whether they're in front of you in the office or on the phone or virtually. We review the SAR, the screening activity report through OneID on a every 2-month basis. And, we might be kind of increasing the frequency of that to monthly now that we have the ability to kind of try to maximize patients getting up to date while we can. And so getting patients in, we're prioritizing overdue PAPs, mammos, fits. We're recalling through the admin staff to advise patients to book their OBSP mammograms. We're e-faxing the fits now. It's paperless. It goes directly to the patient after you fax the requisition. It's nice in that sense and regard. And from my end, it's just making sure that I actually look at that CPP, part of the CPP that's showing me my preventative health care, and making sure that I'm reviewing it with patients. The 1 or 2 minutes that it takes to just say, hey, you're due for your PAP. I know we're ending this phone call, but call my office back. Let's book you in. My office is open. We're here for you. We want to make sure you're up to date, and we shouldn't let this fall behind. It just takes 30 seconds to a minute to make sure that everything is up to date. And I'm trying more than ever now to make sure, because like I said, every appointment now is even more important now, to make sure that we're adding that extra step to make sure patients are up to date.
Very similar to Sofia. And I think what it is because the technology, the tech is there, at least for the mammogram and fit aspect, where you're faxing in, you can just simply send a fax for the ultrasound for the Ontario breast screening. That definitely makes things easy. The PAP part, as well, it's checking that chart, checking to see, taking that extra second or so, saying you're due for a PAP, call back. And for us, luckily I am in a family health team. So we actually created our preventative health program, where we actually have our nurses actively recalling people as well who are overdue, using the SARS report as well. So again, just because it's just recently been allowing us to get back into the swing, so we're starting to ramp that up. And then in addition, because we know there's such a backlog, we've actually also assigned an admin to that aspect as well. So we have an active program where actually our nurses, and again, luckily we're in a family health team, so it works, is actually actively engaging to get the fits up to date, the mammals up to date, where you could just simply fax in the recs, and then actively calling people in for the PAPs. Now, the other side of that is, which I think is very important, is the immunization piece, and that we don't have an active program for recall or anything. So that, and for me, because of the way my practice is, I know let's say the preventative piece for the cancer screening is taken care of. It's the immunization piece that I haven't automated into a system yet, let's say in my practice. So it is taking that extra second, check the CPP, something's not up to date. Okay, let me make sure you get your pneumovax. Let me make sure you had done your flu shot. Let's make sure you have done your tetanus and all those things as well, which would be coming up to date. So just doing all those little checks and balances helps. But again, working with what we have, it's growing. There may be a point where we come up with a system that automates that, and maybe we pull some of the data from the EMR and actually start that recall process as well. We're not there yet. So right now it is basically on the physician at this point for the immunization piece to go over. Childhood immunizations, all those things, that's standard, that's being part of. And that probably is more encouraging the parents to ensure, to make sure they know we're safe, we're following all the guidelines, you're safe when you come in. And I always, same spiel I tell them, there's barely anyone here. We have staggered appointments, so we make sure that you're gonna be safe. And I think that's the reassurance piece that has to be from the physician to the patient. And, we have the OMA campaign saying, go to see your doctor, we're open for business, those things as well. So it does help at different levels, but coming from the physician to reassure the patient that they're safe when they come to your office is a big thing.
Those are definitely some good, very practical tips that can be implemented. I wanted to switch gears and ask about some of the learnings that you've had on the business side. So we know that many family physicians in Ontario function like small businesses, and we know that COVID has had a huge impact on sort of the business aspect of your clinics and how you run your practices. How have you adapted from the business end, and what are some learnings that you've taken away over the last number of months that we can share today?
So with regard to the business element of every family medicine practice, I think when it comes to the PEM models and the FOs in particular, the out-of-basket codes have been probably the biggest hit from a financial perspective that we're unable to use because we're seeing quite a few patients virtually or even just on the phone. Now, with the recent info bulletin specifically regarding diabetes management, which was a big aspect to the out-of-basket codes that we were missing out on, the ability now to use the KO81 equivalent as a KO30 to make sure that you get your Q code bonus has been nice, that they've finally introduced that aspect to things. Now, at the end of the day, that KO81 is still in basket. So as much as I can, when I do have the opportunity to have those virtual appointments for a diabetes check, I do try to encourage the front staff to optimize the patient, to set them up to say, we're going to try a virtual visit. Most times, I'd say probably 7 times out of 10, it ends up working out. Maybe 1 or 2 times out of 10, there's technical difficulties, and 1 out of 10 people don't actually have an email, so the process itself can't even get started. So it's actually been really successful from at least my small kind of practice perspective, to be able to still have a KO30 OTN visit when I make sure that I mobilize those resources from my front staff and try to empower and educate the patients. And another kind of element from the business aspects of things that there's been a drop off of is maybe from a optimization of how to manage third-party billing for many offices maybe that don't actually have e-transfer or Interact cards for transactions. We've switched to the e-transfer aspect of things just to make it easier for patients to make payments if they need notes or paperwork done. And then on my end, I end up just sending a receipt once we receive payment. But just trying to queue up the patients from an efficacy perspective. So making sure that if there is paperwork to get done, send it to our clinic email and the front staff will upload it so that it's ready to go when we chat with you. I think the efficiencies of that will also make the practice more efficient again, in order to make sure that the business aspect of the primary care practice is still, a well-oiled machine. So I'd say those are probably the 2 aspects that I've noticed that I needed to tweak in order to make sure that we're optimizing, the business end of things.
Helpful. Andrew, anything that you'd like to add?
Yeah, I think essentially building on what Sofia said, I think first and foremost, if you don't have OTNs set up, absolutely have that set up, because if you do want to start to access some of the virtual out-of-basket virtual codes, out-of-basket codes, you should have the OTN set up. The way we run it, and just the way we do it, we fortunately have a lab in our clinic as well. So when we do diabetes assessments, the same day the patient will come and do their blood work, fasting blood work, their height, weight, blood pressure, waist circumference, feet, and all those things are checked by our nurse all on the same day. And then there's a follow-up virtual visit that's booked for them 2-3 days later. So that's the way we run it kind of at our clinic, just to be more efficient. In terms of future and looking what kind of the bonus or the benefit of what we're moving toward the virtual side is, you can kind of look at it now as what I feel is the physical space you have probably is not as important anymore. We have 4 doctors in our clinic and we have 13 examining rooms, we have a staff room, we have all those things. But now, once we've started this whole staggered approach and 2 doctors can work virtually and the other 2 docs are in clinic, you realize the amount of space that we need is actually less. So when we look at it moving forward, we could now actually add a 5th doctor keep the same amount of space or even downgrade. So therefore, on a business side, we've actually found a way to decrease our expenses as a result. So now if I feel like if people start to look at it that way in terms of there's some cost savings there as well. I think there's a benefit. When we come out of this, there may be some benefit that makes you come, because if everyone's adapted to a certain way or style, I think that's one of the main things that I would say has been helpful to start looking at now into the future of the business side of things.
100% agree with you. And it's economies of scale. There's a virtual care working group that the ministry and the OMA have put together to look at how to bill and how to be able to organize things a little bit differently. There's no question that things are going to evolve over the next couple of years to being supporting virtual care. I don't think in-person care will ever go away, at least I hope it doesn't. And I can't imagine it will, but how do we do it more efficiently? And we're spending a lot of energy in our own clinic thinking about that. And I think it challenges how the old business model of the smaller practices are going to be over the next, I think, 5 to 10 years as we move more to team-based, more to population health-based care, more to utilizing virtual care. And I think what this pandemic has done is accelerated the transformation that we're going to see in our healthcare system here in this province.
And that actually is a wonderful segue to a question I have for all of you, which is, what is the one big takeaway that you've each had that you would, at this point in time, several months into practicing under the restrictions of COVID-19, what is sort of that one lesson learned, that one takeaway that you would like to pass along to a peer?
For myself, I've found that even though, we're trying to, everyone's playing their part to, socially distance, we're trying to, flatten the curve, trying to minimize cases. It can feel a little bit isolating now, even more than ever, being a primary care physician, alternating days with your colleagues, not actually being able to engage, discussing cases, all that kind of stuff is out the window for the moment. And it can feel very isolating. A lot of people can, I have other colleagues of mine and we chat and we say, what are you doing when, for A, B, or C? And I think that if there's one thing that I would encourage people to do is to keep up to date and see what other colleagues are doing. One of the biggest aspects to that I've introduced into my own kind of monthly practice is joining the COVID-19 community of practice through the OCFP. They hold monthly webinars. I can also post the link for that for anyone that's interested in joining them. But I find that it's very up-to-date, timely information. It helps me it provides me with information to apply to my own practice. And it just helps me feel, rest assured to say, we're in this together, there is support there, and we can kind of move through to get through this together as a community of practice.
Same as Sofia, building off that, but more so, I would look at it from the patient perspective, what they kind of expect from their physician now. With the whole virtual care aspect, every aspect in their life has become virtual. They can easily book online, they can easily do a virtual, this, that, and the other, they can easily email. So I think embracing that and understanding that that's kind of where we are right now with medicine, and understanding that what we used to do probably is not going to be the way anymore. This is the way it is. It's moving forward. So really just trying to understand how can I be accessible to my patient? I say this to my patients all the time. The third or fourth doctor you meet will always be the smartest doctor, because they already saw what happened here, what happened here, what happened here. So they're able to diagnose you, let's say, effectively. So imagine as a primary caregiver, you're able to be more accessible through email, virtual, or thing. You're actually providing better care as well. And I'm sure that was the big trend everyone saw. Everyone's backlog disappeared in March and April, and all of a sudden you were generating back patient visits and all those things again. So essentially you're working almost on same day appointments or even a little bit more. So allowing yourself to stay there, I think, is key. You want to be able to have that accessibility to patients, I feel, and I feel that's actually better for care as well. So when you embrace the virtual call aspect, the telephone, the messaging, it allows the patients to be accessible to you. And I think that overall will help you as a physician, because you get to see kind of what happens over the time course of symptoms, but also for the patient as well. So I think that's kind of a good thing that has kind of come out of this whole thing.
What I've heard from a lot of colleagues across the province is that a bit of the joy of family medicine has left because we haven't had the same patient interaction, we haven't had the same staff physician interaction, we haven't had the same physician interaction. And my guess is that this technology is going to enable more of that kind of interaction as we go forward. So as Andrew says, in terms of being more accessible to our patients and I suspect our colleagues as well. And I'm hopeful that the investment that all of the various EMR companies are going to put into online booking and instant messaging, et cetera, is really going to enable us to spend a bit more time with our patients and utilize the technology to assist, as opposed to what it seems to have been for the last 15 years, which is to add a lot of extra time into our day, inputting data, et cetera. So we may be at that inflection tipping point. So leaving with a bit of a positive message there that hopefully when we talk about this time, we'll say it actually helped us to spend more time with our patients in the long run.
Thank you so much, David, Sophia, Andrew. We're so grateful that you were able to join us today and share your experiences in the field with other family physicians that have joined us. Thank you so much. The one or two questions that came in that we haven't gotten to, we'll reach out to you independently to make sure that we help you answer them. Thank you so much. I hope you all have a wonderful day, and we'll see you at our next webinar.